I'll give a brief introduction about extrapulmonary tuberculosis. So, in fact, extrapulmonary tuberculosis uh, is a what we can say it says about the immunity of our community. So, whether if the community is immunosuppressed, the extrapulmonary TB can go up. So, if you look at the early data, 1980s and all, then EPTB used to be about less than 10% of all tuberculosis, but now it is much more. And out of the extrapulmonary tuberculosis, you can see here the commonest are lymph nodes, pleural TB, GI TB, bones, genitourinary, CNS, and spine. So they say that apart from nails, teeth, and hair, any other organs can be involved with extrapulmonary TB. So it can involve any organ. So the controversies come when it is thoracic TB, like for example, if there's no pulmonary involvement, but if there's pleural effusion, so that is pleural TB, that is also considered as extrapulmonary. But if there is concomitant pulmonary plus pleural, it is pulmonary. Or otherwise, if there's pulmonary with extrapulmonary, you might call it a disseminated tuberculosis. And also, if there is isolated lymphadenopathy, that again we take as extrapulmonary TB lymphadenitis. So diagnosis, as mentioned by many previous speakers, is not straightforward. It's quite difficult. You try to achieve histological or microbiological diagnosis by smear and culture or by this nucleic acid testing. But sometimes we have to treat on clinical grounds. So when there's a strong clinical suspicion, you have to treat for suspected or most likely, most probable extrapulmonary TB. That is again not uncommon. Because it's a great masquerader. That is, TB is known as a great masquerader, and especially extrapulmonary TB, because usually it's in deep tissues, deep organs, and diagnosis and the testing also is very difficult. You need a lot of sampling, which is sometimes not very easy. So it's actually a challenge. So the new rates, it has gone up to about 15 to 20% of all TB cases among general population, like normal, like immunocompetent TB patients. But when you talk about HIV patients, the extrapulmonary TB rates can go up to even 50%. So when you diagnose extrapulmonary TB in the relevant context, we have to exclude HIV infection as well. Generally, EPTB is non-infectious. However, laryngeal TB can be highly infectious. But otherwise, if there's no pulmonary involvement, it's usually EPTB is non-infectious. So it is associated with the poor immune status, especially HIV and low CD4 counts, other general immune suppressive status, which includes malignancies, use of chemotherapy, organ transplant patients, and malnutrition. And also it has been increasingly found in females and extremes of age, and also in poor social economic status. And also there are some genetic factors newly identified which can predispose to extrapulmonary tuberculosis. So when you are when you encounter extrapulmonary TB patients, it can be any organ. It can be, as mentioned earlier, it can be your lymph nodes or pleural or CNS, central nervous system, or it can be genitourinary or gastrointestinal tract or abdominal tuberculosis. You try to achieve a microbacteriological or microbiological diagnosis. So when you take samples, generally we request to take samples in saline plus formalin, because we need to look for microbiological evidences. So these saline samples can be tested, even solid samples can be tested for AFB smear and cultures, and also gene expert and other PCR testing. And also histological diagnosis is also important, where you see these caseations and multinucleated granulomas. If you cannot achieve microbiological diagnosis, you go by this histological evidence. Always you exclude coexisting pulmonary TB. So clinical features, usually there are a lot of constitutional symptoms like fever, night sweats, loss of appetite and weight, and tiredness. And of course, then it depends on what is the organ affected, organ specific symptoms. For example, if you meningitis patients will get headache and other CNS symptoms. So likewise, there will be local symptoms as well. So with that introduction, I will briefly discuss about the commonest or the most serious extrapulmonary TB manifestations. So CNS TB would be one of the most it's not the commonest, but it will be most important in the sense that it can have very poor prognosis and can leave a lot of bad sequelae. So patients can be severely affected with this CNS TB. So TB meningitis would be the commonest CNS form of CNS TB, but you can also get tuberculomas and spinal TB. So that CNS TB can be there in about 1/5 of patients with miliary TB. So when you have miliary TB, you can always think that this is usually the patients can have disseminated tuberculosis. And CNS TB would be more common in patients with HIV. And of course, it's a medical emergency because it has a high mortality of about 40%, and also can go up to 40%. And also about 1/4 of these patients can have permanent neurological sequelae, so which is quite poor prognosis. Okay. So it's usually hematogenous spread from primary tuberculosis infection, where these mycobacteria can go and deposit themselves in all these deep planes of like CNS tissues, subarachnoid space, and other areas where they can develop meningitis or tuberculomas or even spinal tuberculosis. So cranial nerve palsies, vasculitis, hydrocephalus, cerebral edema. So all these complications can be common, as you saw in some of the CT images that was shown in the previous lecture. This can be usually a subacute or a chronic infection, both in adults and young children. So they can present with classical neurological features like neck stiffness, cranial nerve palsies, but commonly they can present with very non-specific features like headache, fever, vomiting, photophobia. Especially in elderly, they would just have anorexia, they are not eating, and they just gradually decline without any specific CNS symptoms. So that is why it becomes a very diagnostic challenge. Even in young children and infants, there can be neurological features like seizures and cranial nerve palsies, but commonly they can have failure to thrive, irritability, poor appetite. So then that needs a lot of suspicion, then clinical suspicion. So cerebral edema, obstructive hydrocephalus, and even strokes and endarteritis. All these complications can be there in CNS TB. You earlier saw some images with basal meningeal enhancement in the TB meningitis. You can see here it is again. See here this basal meningeal enhancement. That can also commonly come with multiple cranial nerve palsies. Tuberculomas, of course, can often be asymptomatic, and they can also have some non-specific symptoms like headache, fever, weight loss. But depending on the site of the tuberculoma, they can have various features like focal neurological signs, cerebellar signs, and even papilledema. Sometimes, if it's a basal ganglion involvement, there can be movement disorders also. So it all depends on the site of the tuberculomas. And commonly, these tuberculomas can be subtentorial, so they are in the base of the brain, not on the hemispheres, but cerebellar tuberculomas can be common. So what is the CSF analysis in TB meningitis? So usually we see a lymphocytic meningitis with very high protein. Proteins can go up to, so normally is about 0.5 or 0.45. It can go up to even 3 grams per liter, which is very high. So these very high proteins, lymphocytes, and also very low sugar, about 1/3 from the CSF, from the blood sugar. These three usually, when these three are together, then you tend to think about TB meningitis, but there are a lot of other differential diagnoses which also can have a lymphocytic meningitis with very high protein and low sugar. For example, chronic infections like fungal infections, brucellosis, and even malignancies, primary brain malignancies and lymphomas. They all can have these three combinations. So it's again not very easy to diagnose. So you go for the microbiological testing. Usually for CSF, AFB, and cultures, especially for AFB, they request a large volume. So the recommendation is at least about 6 ml, but if we can at least take about 2 ml, that would yield a better diagnostic yield rather than just a few drops of CSF. So when you are doing CSF, you can try to achieve a little larger sample. So cultures, of course, takes time, but now we have these TB PCR testing, which are very quickly, which can give the results. So what is ADA, adenosine deaminase? It is an enzyme from secreted from this sensitized. So it's from the leukocytes. So it's an adenosine deaminase enzyme, can be very specific for tuberculosis. However, this ADA can also be present in pathogenic infections. So before doing ADA in CSF and also in pleural samples, it's good to see whether it's a lymphocytic sample. If it's a lymphocytic sample, the ADA has a very high predictive value. Otherwise, if it's a neutrophilic sample in pathogenic infections, ADA can still be positive. So it might be difficult to differentiate. But it's a good test. It has a sensitivity of about 85% with the specificity of about 90% CSF ADA, adenosine deaminase. Whereas TB-PCR, of course, as mentioned by the previous speaker, there are a lot of techniques. Gene expert is one, then there are other different techniques. So based on the technique, there's a range of sensitivity of about 40 to 70% with a very good specificity, almost approaching 100%. But the sensitivity would be higher in ADA, so it's a good test. However, there are false positives like in cerebral lymphomas, viral meningitis, HIV, CMV, and cryptococcal other fungal meningitis. Of course, in some of these things, if you really look at the titers would be very low. However, in lymphomas, they can have high titers similar to TB meningitis. But these viral and other fungal infections can sometimes be differentiated. So anyway, it's a good test that we commonly do. However, it's not available in the government sector. It takes about cost about 12,000 rupees. Interferon gamma and MAN2 test you'll be hearing when in the next lecture, probably during latent TB. Those are also helpful in the diagnosis. So we always exclude pulmonary TB because it's an infectious form and it helps in the diagnosis. CT brain is a must. So we do brain imaging, which will show sometimes usually it's normal, but it can show the complications like hydrocephalus and tuberculomas. And also sometimes there are strokes, as mentioned in some of the previous slides. MRI can be done. However, you don't wait till MRI and other contrast CTs to start treatment. Based on your other clinical evidence, you can start treatment. In tuberculomas also, that as I mentioned, it can be infratentorial in the lower part of the brain. CT and MRI would be helpful, and the proteins, CSF proteins, can be very high. But always there are differential diagnoses as mentioned here for ring enhancing solitary lesions. They can be solitary or multiple lesions. So when they are solitary lesions, like shown in this image, pyogenic abscess or bacterial brain abscess, and toxoplasmosis, malignancies, neurocysticercosis. Some of these things again can be multiple abscess as well, multiple lesions. So again, there are a lot of differential diagnoses, and you need to take the full context into the picture to come to a diagnosis. What about spinal tuberculosis? This is actually the Sri Lankan survey where we did about a long time back, about 30 patients. And as mentioned by one of the previous speakers, again you can see here lower thoracic and the lumbosacral area would be the commonest predilected areas for the spinal tuberculosis, whereas bacterial TB would be mainly the upper lumbar region. And end plate destruction and paraspinal soft tissue masses like psoas abscesses and other collections can be common in the spinal TB. Here you can see this end plate destruction, and also it going to the discitis and destruction of the disc, which is a very advanced feature. But in early spinal tuberculosis, you get mainly the end plate erosions, end plate destruction, inflammation, and paraspinal inflammation with preservation of the disc. But later on, the disc can also get involved. And of course, this patient has an acute angle of the spine, which is acute kyphosis, which is called gibbous disease in tuberculosis, which again needs surgical correction. So treatment-wise, CNS TB, you go for a lengthened course, about 1 year course of anti-TB. Not the standard 6 months, you can extend, mostly in meningeal TB and spinal TB sometimes. So there are few instances where you can extend the course of anti-TB treatment, that is meningeal TB and also skeletal CNS TB, skeletal TB, and also disseminated TB. You tend to give a longer period in extrapulmonary tuberculosis. Also, steroids can be given. So there are indications for steroids also in extrapulmonary TB, like CNS TB and also genitourinary TB and pericardial TB, and some of the lymph nodes. Also, we tend to give some steroids, whereas in pulmonary TB, we don't generally give steroids. So when there are complications, you have to treat them medically or surgically. So hydrocephalus, furosemide or acetazolamide can be given, and surgical shunt insertion also can be considered. And if the patient is not improving, you have to think about the complications like hydrocephalus or infarctions as well. Sometimes they can have severe SIADH, so that also can be a cause of deterioration. I'll quickly go through TB pleural effusions, about 4 minutes. So TB effusion is the second commonest after TB lymph nodes. So they can manifest as a primary or a reactivated disease. So usually these subpleural caseation, this mycobacterial foci, they can rupture and cause pleural infection. So pleural TB can be a multibacillary disease or a paucibacillary. So generally it is a paucibacillary where you cannot readily detect mycobacteria, but sometimes there are a lot of active infection, which is TB empyema. So there's a multibacillary form as well. So there's a lot of immune system also, immune reactivation, and which can cause a reactive pleural fluid in TB pleural effusions. So clinically, they can usually be acute or subacute. Pleuritic chest pain, non-productive cough, fever, dyspnea lasting generally for about 2 to 3 weeks is the commonest presentation. And it's usually unilateral and usually moderate size effusions. However, when there's TB empyema, it can be even chronic, and there can be a lot of high fever as well. So this is a picture of empyema necessitans, where this can occur in tuberculous empyema and also pyogenic empyema, where there's active infection in the pleural cavity, which can also spread into the soft tissues, and this can even rupture. So these need surgical interventions. And sometimes pulmonary TB, they can have bronchopleural fistulas and cause pleural TBs, and primary pleural TBs also can go and infect the lungs as well. So this is usually pulmonary TB causing a bronchopulmonary fistula and causing a TB empyema. Right. So ultrasound scan would be very helpful to diagnose. It shows a lot of features like these septations, and it helps us to guided aspirations. We can do acid fast bacilli, which is low sensitivity, which has a low sensitivity of about 20%. Culture has a better sensitivity of about 40%. But when it comes to ADA and TB PCR, the sensitivity and the specificity are higher. So ADA has about 90% sensitivity and specificity. This TB PCR testing varies from 40 to 70% with a very high specificity. So pleural biopsy and especially thoracoscopy, that has advanced the management, because we can visualize the pleura and take biopsies. So generally, pleural fluid is lymphocytic and exudative, as you can see here. So protein content is high, pH can be low, glucose again low, which is usually lymphocytic. But at the very early stages, within the first 2 weeks, especially in empyema, it can be neutrophilic. So neutrophilic effusions do not exclude tuberculous effusion, but then of course we repeat after a couple of weeks, and then probably the effusion can be lymphocytic. Mesothelial cell counts is very low because there's a generalized pleural inflammation, and mesothelial shedding is very minimum in TB effusions compared to other causes like malignancies and all. So it might be a useful marker to diagnose pleural TB. And eosinophil counts are also very low. If it is high, you have to think about air mixing. So it is either pneumothorax or repeated pleural aspirations, which has introduced air into the pleural cavity. Otherwise, its eosinophil count is very low. So in the interest of time, I will go through quickly. It's about the ADA and the other tests that we have already mentioned. There are always false positives for ADA, like bacterial infections and other fungal and brucella infections. So pleural biopsy is helpful. These are some thoracoscopic images where you can visualize the pleura and take guided biopsies. But if this is not available, you can even still do blind biopsies and they are still valid, because in TB it's a generalized infection. Unlike in malignancies where you have sporadic lesions, in TB you have generalized involvement. So even a blind or a close biopsy still would be helpful. So treatment is standard, but when there are a lot of pleural, like acceptations, you can give interpleural adhesiolysis like streptokinase. Ocular TB, I'll be very brief. It can be extraocular or intraocular. The intraocular ones are the more serious ones, which are the anterior and posterior uveitis, choroid retinitis, or endophthalmitis. So this is a picture of scleritis. Then the flictanular keratoconjunctivitis, which is the involvement of the sclera. Here you can see pus in the anterior chamber. So this is anterior uveitis and this is posterior uveitis and choroid retinitis. There are a lot of differential diagnoses, including toxoplasma, cytomegalovirus, HIV retinopathy, sarcoidosis, and vasculitis. So it's again a very difficult, challenging clinical condition to diagnose. We can diagnose by, other than the usual tests that have been mentioned, sampling the anterior chamber or the vitreous humor, but I think it's a quite, we might not have all the facilities in our setup, so we don't see these things done routinely. So just a few pictures: TB lymphadenitis and TB skin TB. So there are lupus vulgaris is the commonest form of skin TB. So with that, I'll stop my talk. In summary, so extrapulmonary TB can involve any organs of the body except a very few, like hair and nail, and the commonest would be as discussed here. Thank you.